Okay, so we have the 30,000 foot look on page 47. And again, very similarly, acute or non-acute presentations, diagnostic workups, maybe an inpatient stay depending on the presentation, maybe an outpatient admission after a cath. The trigger is the surgery. There is a potentially a pre-trigger situation if a patient is in the hospital awaiting a CABG as opposed to going home, depending on the circumstances. And then the post-trigger episode, which would again be recovery complications, readmissions, discharge planning, handoffs back to a outpatient environment, follow-up again by the operating or the interventionalist surgeon. Go to the next page. The black and white's not the best, but you can see again efficient use of the inpatient environment, appropriate techniques, good outcomes, acutely reduced readmissions through good coordinated handoffs and discharge planning, and again appropriate medication use in the inpatient setting. And again for Medicaid, there's a per diem. On the Blue Cross side, there's more of a cost-based kind of activity, and very often the cost of the environment can be more of a factor on the commercial side than on the Medicaid side. Then we have, again, the environment, and we see on page 49 that we have about 140 Medicaid CABGs, 290 Blue Cross CABGs in the calendar year 2011. Again, on the Medicaid side, we have a little bit more detail. The vast majority of them were admitted on the day of surgery, and a small number were in the hospital at the time of surgery. And again, about 3 dozen operators, surgeons doing the procedure in the state. And again, we have a cost listed there for Arkansas Medicaid. So let me turn this back to Dan for the details.
Thank you, Bill. So starting on page 51, the same format that we walked through for PCI. The trigger for a CABG is any of this is when we see a CABG in the claims data. The episode starts at the inpatient admission during which the surgery takes place. It continues through a period of 30 days post-discharge from the facility. And similar to PCI, the same types of services and readmissions and so on are included in the episode. There are exclusion criteria that we talk through, again, select comorbid conditions. The emergency CABGs we discussed earlier, so they're not only excluded from the PCI episode, so a PCI that converts to a CABG on the same day, but those CABGs would also be excluded from this episode as well. And on page 52, again, a similar set of episode adjustments with comorbidities, age, different outliers, and so on would be applied. Quality metrics we will come back to in a moment. And for Medicaid, the principal accountable provider will be the surgeon, cardiothoracic surgeon that is performing the CABG.
You mentioned that I'm going between two different pieces of sources here. The episode starts for the hospital admission. That seems to be two separate situations. If a patient has a cath and then goes for a CABG, that's a different situation than if a patient has a cath, goes home, and comes back in for a CABG. The costs are substantially different.
Right. And that's actually what I wanted to spend a minute on here with you guys. We've had a lot of feedback from and quite a lot of discussion with our clinical advisors on exactly this issue because, like PCI, the pathways of patient presentation are very different. If you actually flip back to page 47, if you on the screen can flip back to 47 as well. On the patient pathway in the presentations, you can see there's some patients that come in through the ED and may or may not have a cath immediately after that. Some are then sent home. We also know our clinical advisors are very clear. If you have a patient that's on Plavix, You may need to actually wait a few days before the CABG. At what point is it safe or more effective to send the patient home for another number of reasons versus keeping the patient in the inpatient setting? All those lead to you also have some cases where the patient sees the cardiologist in an outpatient setting, has a directly scheduled CABG, and shows up at the inpatient on the day of the CABG, which is, by the way, the vast majority of some of the cases that we're seeing in the data. But there are so many different presentations here, and so we really spent a lot of time with the clinical advisors getting input on where would you start the episode, what costs would you include in that pre-procedure window to most effectively account for that. The current proposal that we would invite feedback on is that the episode would start at the start of the admission for the actual procedure. And the reason for that would be, I think we've seen other models where the CABG episode would start, say, at the presentation to the ED. The reason why we didn't start it there was you have so many varying pathways, as you just mentioned. You might have a cath, you might be sent home. Some folks that you need to hold them in the hospital. That there would be many, many days for that. I think our clinical advisors mentioned you need to account for the difference of those pathways and severity. At the same time, there may be cases where there are opportunities to improve the kind of cost effectiveness of it with someone that's waiting in the hospital could have the CABG more quickly with a lower length of stay. So how do you fairly structure the episode model to reward clinicians that are really proactive about things like that, while at the same time accounting for the very heterogeneous pathways that come in? And just to clarify what we mean by the episode starting at the inpatient stay. So if you came in to the ED on a Monday and then also went into the cath lab on a Monday and actually had a CABG scheduled for Saturday and left was sent home and came back on Saturday for the CABG would start at that point. In other cases, when you are scheduled directly from the outpatient cardiologist for a scheduled procedure, come into the inpatient setting, the CABG would start kind of at that same day as well. At the moment, if you have a 5-day length of stay that directly links into the CABG, that is part of the episode. The question is, for feedback from this group, is by creating that structure in place after risk adjustments and exclusions, is that an appropriate episode design such that it creates rewards for someone who appropriately can either send someone home when it's best for the patient versus keep them in, and so on? And that is really the question for this group. The design I just mentioned, does that feel right to you guys? Are there questions and other pieces of that you would really guide the payers to be considering in the episode design? So let me pause here because this was such a topic of discussion and detailed input that we've had over the past months. I just want to stop here for additional input from this group.
Dan, if I could make a comment. One thing, this is Steve from Blue Cross. One thing that you need to keep in mind is, we need to get this right. We need your input to help us define the episode so it's most effective in creating an incentive to eliminate unjustifiable cost. But understand, once that episode is defined, we're going to rerun that standard distribution in the graph and say, look, this is the historical cost of the episode defined as we have agreed to define it. And so to the extent that we have inefficiency in the system, it's going to be baked in to that distribution when the targets are set. And so the opportunity for success in eliminating unjustifiable cost should be no greater or no less, regardless of how it's defined. We just need to make sure we define it the right way.
You'll see same format as for PCI. The range of triggers. I think the comments before were very helpful on which codes are in here, but this is for historical data in 2011. The CPT codes we see for Medicaid for CABG and the frequency of those over the course of 2011. So 33518, 33533, and 33519 are the three most frequent CPT codes that we are seeing in the Medicaid data. And on page 55, you'll see the related diagnoses codes for the CABG episode as well.
That question that we had about the number of procedures that were happening that were admitted before the surgery or admitted on the day of the surgery is on page 49.
There it is. I knew the data was someplace.
A little bit less than 15% of providers, or almost 20% of CABGs that are in the Medicaid data are in the hospital for some length of stay before the actual procedure.
Can you answer the previous question about whether these are valve also patients, so CABG plus valve procedures at the same time?
The answer was no, and I know we have some microphone things in the room. That was the answer to the question. Sorry for those in the video conference sites. You'll see the related diagnosis codes for the CABG, with 41401 being the vast majority of the CABGs that we see. Again, this is for Medicaid data.
One more thing from Fayetteville.
Yep,
Could you go
please.
back to the previous? Could you go back to the previous slide?
On page 54.
One more. Whatever the slide was where you showed the average cost per episode of CABG.
Yep.
That
is
page zero missing
page.
there?
Sorry, that's page 49 for folks flipping. I'm sorry, what was the question?
Is there a zero missing in that average episode cost?
No.
So what you're telling me is that Medicaid pays $14,500 for a CABG?
Yes and no. The Medicaid program pays a per diem, which is something that we've been doing for a long time. And yes, the initial check is what you see. And what happens at the end of the year, there is a reconciliation process that all the hospitals submit cost reports to, and so a partial restitution of missing revenue occurs. It is what I would say fairly complex and arcane, and but for the sake of counting, that's the cost on the initial payment, and a lot of that's being driven by the per diem.
And on that, in general, for the Medicaid data, I mean, the cost, at least what a Medicaid would see in the claims data, the cost of one day in the hospital for, for someone recovering from a limb injury would be the same as the cost per day for someone recovering for a CABG, and so that's the nature of how the per diem payments for Medicaid today are structured. Again, on some of the exclusions that are in here, some of these will look familiar based on the PCI discussion. 57 has some of the risk factors that are included and will be tested as well. So similar to the conversation we had on PCI, I would ask if clinicians in the room or on the video conference sites have suggestions for other exclusions that need to be put in, other risk factors and comorbidities to look at the variation in historical costs on. We would love to get the help, follow up with you afterwards and get some of those, if that's okay. Great. We had a comment of lots, so.
One more suggestion for risk factors.
Yep.
Tobacco abuse, current tobacco abuse. Number one cause of graft failure.
Is that something that's going to be accurately coded in the claims? I know when we've looked through this in the past on at least Medicaid claims data on any of these sorts of things, the percent of patients with any of this stuff coded is very small. And so for this to be kind of factored in, a provider would have to enter all that stuff in the portal, and that adds a level of administrative complexity for the providers.
Well, for those of you who are curious, especially here, we did have two cardiovascular surgeons as experts. We didn't have our cardiologists serve as the cardiac surgeon experts, so I'll take David and Tom off the hook. But
What about whether or not this is a re-op CABG?
Re-op CABG. Yeah. Sorry, for folks that can, we did have explicit discussion of that, redo CABGs, and to account for to look at the historical costs of those, to see if those are so different that they should be excluded, a risk factor, a sub-episode, and how those would be accounted for.